Awesome. Thank you, Christina. So I'm Erica. I'm one of the MedPeds fourth years who's graduating this year, and wanted to do a talk on pediatric obesity in primary care, mostly because I'm interested in it and have learned quite a bit about it this year, but certainly uh, don't profess to be an expert. So I welcome comments, questions along the way, and hopefully we'll all learn something together. I know I certainly learned a lot putting together this talk. So, our objectives today. One is to understand the pathophysiology of obesity as a disease with biopsychosocial drivers. Develop a framework for evaluation and treatment for obesity, particularly in children and adolescents, although I think you'll find that a lot that we talk today is applicable to adults as well. And then number 3, discuss how COOC can more effectively serve and support patients and families in managing excess weight. So I guess to start, why do we care about this? And I think everybody is familiar with these kinds of graphics. Obesity is becoming more prevalent in the US. You can see in the state of Minnesota between about a third of the population of adults, and this is kind of self-reported data, fall into the obese category. And it's not only adults. You've probably heard that it's kids as well. So this is data from the NHANES survey, looking at the difference between 2000, so 21 years ago, and then 2015. You can see that over the course of 15 years, from one pie chart to another, the number of kids who have had severe obesity, and that's like class 1, class 2, class 3, has doubled over the last 15 years, and going from 2000 to 2015, 2016, whereas before, over half of kids fell into a normal BMI or body mass index category. As of 2015, 2016, less than half did. So more kids than not have overweight or obesity. At COOC, based on some preliminary numbers I just tried to pull together from EPIC, at least 667 of our pediatric patients have a diagnosis of obesity or have a body mass index that is 30 or more. So putting them into that category of obesity by body mass index. And this is likely an underestimate, as I had some trouble pulling some of the BMI percentile data for the kids. So I think, in the back of my mind, there is maybe some disagreement about, is obesity actually a problem? Is it actually an epidemic? Is it blown out of the water? So I think to start, before we kind of dive into things in more detail, we have to agree on some definitions. So specifically here, since I know we're not all doctors, when we're talking about BMI, it stands for body mass index, and it's calculated using a formula of weight in kilograms over height in meters squared. And this is kind of your weight for your height, or how proportional a person is. Using this definition or this formula, the CDC puts people into, weight categories. In people who have a body mass index of less than 85%, that's considered a normal weight. And then going up from the 85th percentile is where you see overweight and obesity kind of broken down. So for kids, when we go by percentiles, it's over the 85th percentile to the 95th. And then obesity starts at the 95th percentile. And I think, in EPIC right now, the way we have it, when you put in the ICD-10 codes, it's either the kids have obesity, like above the 95th percentile, or they have severe obesity. They don't necessarily break it down into classes like I have here, but there is some thought that, that the higher the class of the obesity potentially comes with more health risks. So it is potentially useful to cut out those classes. So at 120% of the 95th percentile, or if you take that number and multiply it by 1.2, we call that obesity class 2. And at 1.4 times the 95th percentile, that's obesity class 3. So again, a little bit different from how we classify in adults, where it's just strict number cutoffs, above 30, it's obesity class 1, above 35, etc. And I think, as we can see from the growth chart, it's because kids are growing at the same time in height, as opposed to adults who have reached their kind of final height velocity. And so the actual BMI number will change as they grow, but that's why we track the percentiles. And I think the key here is that, by measuring BMI, what we're trying to capture is risk for poor health due to excess fat and excess weight. It's not a perfect measurement for that, because as you can see from the math, kind of the shorter a person is and heavier they are, the higher the body mass index will be, regardless of why that is. So for example, a short bodybuilder will have a high body mass index, but we don't necessarily care about that as much because they, for example, wouldn't have like the excess fat or the excess weight that presumably produces the health risks, when you have excess fat around vital organs. So that's body mass index and kind of the definition for what we're talking about. I think where the conflict comes from is that we're seeing a lot of conflicting messages in the media. So as part of things like healthy at every size, and the body positivity movements, I think in the last decade or so, there's a lot of argument that we shouldn't be thinking about body size as an indication of health. Meanwhile, in the scientific literature, there's, associations of obesity and body mass index with morbidity and mortality, so risk of disease and risk of death. And in the news, it can get quite sensationalized, saying that obesity is killing people, that you're going to die early. But again, what is the point of all that if people aren't able to lose weight? That's where the healthy at every size movement comes from, and says that actually you don't have to worry about weight. So what should we actually be thinking about when we're, as healthcare providers, trying to counsel patients and families about weight and health, and how can we be mindful of the messages that patients are receiving when, on the one side, on the right side of the screen, you see, I think that's an ad campaign from Georgia, kind of warning parents against, the dangers of obesity. And on the left is an excerpt from a body positive book that's been very popular. So how can we reconcile these things and actually think about how we can help the patient become healthier? And is it actually something that we need to be worrying about? I think a lot of the problem comes from the idea that obesity is a condition that people have brought upon themselves, that it's some sort of choice that people make to overeat or not exercise enough. And as part of that, there's empowering language that says, if you can control your eating, if you can control your exercise, then you can lose weight. I think it's problematic because overemphasizing that kind of if you put your mind to it attitude, again, kind of places the responsibility on people who have obesity, and also doesn't really acknowledge how difficult it is to lose weight, and all of the things that are kind of conspiring against a person who has obesity, how hard that is. And a lot of that messaging often comes from media, whereas the scientific literature, I think for a long time has acknowledged there are so many factors that play into how a person comes to accumulate excess fatty tissue, how it becomes a disease of energy dysregulation. And I think that's the key point, that obesity is a disease of energy dysregulation. I really like this quote. It comes from the Obesity Medicine Association algorithm that kind of gives some treatment guidelines as to how to approach patients with obesity. So I'll just read it to you. Obesity is defined as a chronic, progressive, relapsing, and treatable multifactorial neurobehavioral disease, wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces. And these result in the adverse metabolic, biomechanical, and psychosocial health consequences. And I think this is what we're talking about with, or the idea that the media is trying to get at when they say obesity is killing us, you're going to die prematurely, those kinds of things. It is about this adipose tissue dysfunction. The fatty tissue is not working like it should, or not working in our favor. And, the extra fat mass, just the physics of having extra weight on the body is causing problems. So joint disease, for example, insulin resistance that comes from accumulation of fat, sleep apnea that results from kind of the extra tissue that compresses the airway, and not least of all, high cholesterol, heart disease, high blood pressure, those things that come along with, the metabolic consequences of having extra fatty tissue over and above, the other tissues like muscle and bone, et cetera, et cetera. So it's not just a simple equation of like, eat less, exercise more, and then you'll lose weight. Of course, that's how it would work. That's how you would lose weight. But I think we need to think about, what caused someone to get in this position in the first place? What caused this energy dysregulation and the accumulation of extra weight such that it has become a problem? I think this is part of this theory kind of helps to build a foundation for why it might be difficult to lose weight and why this problem kind of spirals into itself. So set point theory is this idea that your body has a natural place where it likes to settle out, like a weight where it's comfortable, where your appetite or your energy intake will be balanced with your resting energy expenditure. So what your normal metabolic rate is if you didn't do anything. And when you have days, for example, when you eat more or days when you eat less, naturally, your tendency will be to go back to this set point, to back to where you're breaking even, where the energy you're taking in is equivalent to the energy that you're taking out. When you diet and when you lose weight for a period of time, you can come down to a lower body mass index, but the set point theory says that as a result of that, your resting energy expenditure, the energy that you're putting out, will also come down as well, so that eventually, you're going to migrate back towards this body mass index where you originally were, or migrate back towards the weight where you originally were. And this is, kind of backed up by anecdotal experiences of people. Like, it's easy to lose weight initially, but eventually it's hard to maintain your weight loss, and eventually people get back to where they were. And this is the theory then why it's kind of hard to lose weight and keep it off. And I think that's why the whole idea of energy or calories in and calories out doesn't really make sense, because it doesn't account for the way the body is dynamically responding to what you're doing. So like that example I said, if you take in less calories, eventually your metabolic rate is going to go down so that you get back to where you were. Whereas this model, energy in, energy out, kind of presumes like, oh, if you just take in less energy, you're gonna burn more calories than you're taking in, so eventually you're going to lose weight. That's not really how it works. And I think even taking into account this idea, this graphic to the right, the vicious cycle of childhood obesity, again, it kind of presumes the healthy child all of a sudden becomes mildly obese because of, video games, high-fat foods, all study, and no action. And then over the course of time develops these habits that turns into an adult who has obesity. I think it's oversimplifying, what is happening, what is the pathology of excess weight. Even if we play, the social determinants of health game and kind of account for all the social drivers, I think you're still not getting the full picture, because all of this exists in our environment, right? The Western diet or the Western culture really contributes to, the things that make it easy to accumulate excess calories and make it easy to really bring down your resting metabolism, to not do activity, to eat foods that are not whole fruits and vegetables, to eat large portions, all those kinds of things. It's all out there, but again, doesn't quite fully explain picture, because I would argue, even if a child with obesity were placed in a new environment with all of these problems solved, there's no guarantee that BMI would go down, or more importantly, that they would have an improvement in their health status. But it's hard to say, right? That so rarely happens. That so rarely happens that we can take ourselves out of the environment and see. I think what gives a fuller picture is this idea that there are multiple drivers for your appetite and your energy balance. It's not only the environment and the lifestyle, the things that are the social drivers of health. It's also what is your brain doing to integrate all these signals? What are you deciding to do, the choices that you make? But also, what is driving those signals from your body? What is it that makes you feel hungry? What is it that makes you feel satisfied? All those things coming together on top of a foundation of what you're predisposed to as an individual. What are your genetics? What is your heritage? Like what things have your family passed on, and potentially as a result of their environment passed on to balance your appetite and your energy, such that maybe you are more likely to gain weight. So talking about some of the biological drivers of appetite and energy balance, you've probably heard of some of these hormones. Ghrelin is a hunger hormone, tells your brain to eat. Leptin is a satiety hormone, says that you're getting full, gives a sense of satisfaction. And there are other chemical signals that come from the fat itself. Even adiponectin has been found to be decreased in people who have obesity, and it alters your body metabolism in ways that I think are not fully understood. And some other things on the screen you might recognize too. Insulin, controls what your body does with sugar, how much fat, or encourages the body to make more fatty tissue. The mu opioid receptor is over here on the left, and norepinephrine. Both of them actually modulate the hypothalamus, or the place in the brain that regulates hunger and satiety. GLP-1 is another hormone or peptide that makes you feel full, regulates hunger to some extent. And dopamine, of course, is part of the signaling pathways as well. I don't think is too well understood how exactly it does, but maybe it is part of the signaling to tell you whether you're hungry or you're full. And I think the point here is that these signals, these things that make you feel hungry, make you feel full, they're really powerful and not totally under conscious control, right? So how could you blame someone for like overeating or like eating too many calories if, for example, they had really, really high ghrelin? And I think one way that you can see how powerful that these hormones are is by looking at some genetic syndromes. So for example, in leptin deficiency, this kiddo here on the left side of the screen was born without sensitivity to leptin, like doesn't have the receptor, doesn't make the protein, or doesn't make the hormone, whatever. People who have this congenital leptin deficiency don't have this, hormonal signal that tells them they're full. And so what they have is obesity that comes on quite early in age and occurs because they're always eating, never satisfied. They have this hyperphagia. Well, lo and behold, if you give them leptin, as treatment, it normalizes what they're taking in. So they do feel full. They suddenly start to eat much less. And, the before and after, I think, kind of shows it. At 3 years old, you can see that this kiddo has a lot of extra fatty tissue. And then at 6 years old, after leptin treatment, has gotten rid of a lot of that. This hadn't affected a metabolic rate at all, according to the studies. It's just a signal that tells you you're full and then it's time to stop eating. So again, I think a good example of how powerful these hormones and these signals are in your body. Now, this is not like a typical case. The genetic drivers of obesity are actually quite rare when it comes to at least monogenic obesity syndromes, or syndromes where you just have one gene in the pathway or one problem in the pathway that sets things off. The congenital leptin deficiency is one example. Another is a POMC or MC4R mutation. It's just one of the pathways in the hypothalamus that controls hunger and satiety. And I mention it just because there's a new drug that's out that's supposed to treat this POMC mutation. And if you have a patient who has early onset obesity and has this genetic mutation, which they're providing free tests for, then they could potentially be treated with the drug is called setmelanotide, which can reverse the energy dysregulation and potentially put them into a normal BMI category. More common genetic contributors that we maybe don't know how much they're contributing to obesity necessarily is examples of epigenetics. So, for example, studies done on babies who were conceived during the Dutch famine. Their mothers were under stress, metabolic stress during a time of famine, and researchers were able to demonstrate that 6 decades later, a couple generations down, there are still genetic changes that presumably resulted from that metabolic stress. And that's getting passed down. How much does that affect how your energy regulation works? I don't think it's exactly known. Examples of imprinting where you maybe inherit non-functional genes from mother or father. Prader-Willi is a great example of that. Notably, it's one syndrome where they have excess amounts of ghrelin, or the hunger hormone. And so again, you kind of see this patient who eats a ton and is not able to control that, and as a result has obesity. And then again, not known is what is the impact of obesogen exposure. So chemicals in the environment like BPA or some other things that are known to have some effect on hormonal regulation, but again, not sure how much they're contributing to how likely a person is to become or to have obesity. This is a diagram that kind of gets at the complexity, again, of energy regulation. So here you see, I've kind of outlined everything that the brain is doing to integrate all the signals. On the left, you see, smell, sight, auditory, taste, those 5 senses. How do you receive those things in your brain and get integrated into the processing for decisions on what to eat and how to eat. And there's a lot that has to happen, that the brain is kind of coordinating peripheral signals, your genetics, and how they determine how your body is working, as well as internal signals from the brain with conscious and voluntary control, what you decide to do. All of that comes together before you actually have this, again, the oversimplification of calories in and calories out. I think we can kind of boil it down into the brain contribution of energy regulation, I would say, falls into 3 buckets. So you have your cognitive component, which includes your prefrontal cortex, your hippocampus, and your amygdala. So your prefrontal cortex responsible for, decision-making, impulse control, planning, making choices, that kind of thing. Your hippocampus, your memories of food, like those kinds of things. That kind of more voluntary or conscious control of your food intake. And then you have the hedonic pathway, or kind of like the pleasure-seeking pathway. This incorporates areas of your brain like the nucleus accumbens, the ventral tegmental area, places that deal with reward, the pleasure that you get from food or food craving, how your brain is kind of using that part to make a decision about what to eat or motivate you to eat. And then, of course, the homeostatic mechanisms, or the hypothalamus, where your brain is integrating signals from ghrelin and leptin and all those other chemicals from your body that tell you, are you hungry? And I think more simply, you can conceptualize the areas of brain as doing these tasks, the homeostatic mechanisms. I need to eat. I am hungry. I have metabolic hunger. The hedonic area, I want to eat, or I'm craving something. And then the cognitive component, should I eat and what should I eat? I think it's useful to think in terms of these 3 buckets, because then you can kind of get a sense of, or an intuitive sense of, the brain control of energy regulation. All these things together, the peripheral signals, your brain, social drivers, and then of course the genetics, these are the things that together drive appetite and energy balance. And I think supports this idea that obesity is a disease, because it's under such complex regulation. It's not just about, choices. There are all of these factors that are kind of conspiring to make a person consume and hold on to extra calories. And I think the idea behind obesity medicine is that you can help to regulate energy balance by changing the way the brain and the body are signaling, so that body mass doesn't keep increasing and ultimately create more and more harms with excess weight and excess fatty tissue. So kind of coming back to this set point theory, rather than just saying you should eat less and you should exercise, which according to set point theory, if you eat less here, your body's going to resist and try to bring you back to the weight that you're at. How can we use the tools that we have to change how much your body wants to take in, and how your appetite is being driven? Can you reduce hunger? Can you increase satiety? Can you acknowledge all of those drivers so that we can feel good in our bodies and not suffer from the consequences of excess fatty tissue that cause metabolic dysregulation or those other diseases that come from just having a lot of weight and load on the body? And, in the blue here, you kind of see the tools that we can use as part of treatment of obesity-related disease: lifestyle change, pharmacotherapy, and ultimately bariatric and metabolic surgery. Okay, so evaluating and treating obesity. I think the tasks that you have here are a few. So first, you want to identify that there is a high risk BMI and assess the health consequences of that, if there are any. Because if there aren't, then maybe it's not so much a problem. Number two, assess readiness for treatment. Kind of using the motivational interviewing strategies that we're all familiar with. Three, provide resources to support lifestyle change and family goals for physiologic and psychological wellness. And then at the very least, number four, prevent increasing BMI in the pediatric population and health risks that are likely to come with that. So just to show you what the growth chart looks like if you haven't seen it before, this is one of my patients. So in our EPIC, we don't have the fancy extended BMI charts. And so it's tough to see when a kiddo has a really high weight and comes off the growth chart. It's hard to get an idea of where exactly they are with respect to risk and class of obesity. So there's a handy dandy calculator on the CDC website, that allows you to calculate where they're at with regards to the 95th percentile. So just as a reminder, 95th percentile is and above classified as obesity, and then above 120% class 2 and above 140% class 3. So for this kiddo, they're almost at 1.8 of the 95th percentile, putting them into this class 3 obesity category. Once you've, found that there is this potentially high risk body mass index, how do you talk to families? And I don't have a magic wand here to say how to do it. But in general, what the guidelines and what the studies say is that there's a way to do it sensitively. So first, asking permission. Is it okay if we talk about weight as part of talking about your kiddo's growth today? Using preferred terms. So over on the right, you see the results of a survey that was done, kind of asking parents of all these terms, which ones do you find the most offensive? And unsurprisingly, fat is number one, and obesity and overweight kind of follow. So how would you like me to talk about your child's weight? Should we say unhealthy weight? Should we say body mass index? How do you want us to talk about it? Number three, avoiding blame. Of course, I think it's easy to get into these conversations and say, if your child has a weight that puts them at risk for poor health, it's hard not to feel like, as families, that they're at fault. And so whatever you can do to avoid putting responsibility on them or blaming them for what's going on. And, maybe asking, is this the first time that you've heard about this? Or is this the first time that someone's talked to you about weight? Focus on health, so not necessarily the weight or the appearance. And I think this is where kind of the healthy at every size ideas can come into play. We're not talking about necessarily, not liking the way a kid looks, not talking about the weight itself. What we're concerned about is consequences of excess weight that tend to be associated. And then, of course, just seeking to understand where's the family at with this information. Again, is it something new? Is it something they've heard before? Is it something that they're working on, and what have they tried already? And what do they feel? If you're saying it's a problem, do they feel it's a problem? And how? How is the kiddo experiencing their weight in their life? And going forward, this is kind of getting an idea of what you should do next. So I think red flags to look out for are things that suggest that this is not just your quote run-of-the-mill obesity, or like something that maybe needs an additional set of eyes. Is if the kiddo has abnormal linear growth, if it's decelerated or low, suggests potentially an endocrine issue. And if it's accelerated or growing faster than they should, maybe precocious puberty, again, kind of an endocrine evaluation, but in another direction. And if there's developmental delay, both of those are signs that potentially, there's a syndrome or there's something else going on, and maybe you should have a specialist evaluate them. For those kids who have early onset obesity, so kids who go above the 95th percentile earlier in their life before the age of 5, they have a higher likelihood of having potentially a monogenic obesity syndrome, something like a leptin deficiency or POMC mutation, and they would potentially be candidates for genetic testing to see if there's a treatment to address that early. And then this is kind of my personal bias. Any signs or symptoms of an eating disorder or severe body image issues, binge eating, I would send them to an eating disorder clinic just because I don't feel comfortable managing that necessarily. Over on the right, is an example of an extended BMI chart, which sometimes you can get in the EPIC system, which actually shows you where exactly people are falling when they're when the body mass index is too high for the standard growth chart. Next step is to screen for comorbidities. So kind of along the lines of those, figuring out, is this body mass index, it's high, okay, so what? Are there any associated health consequences that presumably are coming with an increased body mass or excess fat? So of course, looking at the weight, the height, the BMI, the height kind of referencing back to whether or not there's an underlying endocrine issue, looking at whether there's high blood pressure, signs of insulin resistance or diabetes, any hormone dysregulation, do they have headaches and nausea, suggestive of pseudotumor cerebri or idiopathic intracranial hypertension, and what musculoskeletal effects have they had? Is there scoliosis? Is there Blount's? Is there the slipped capitofemoral epiphysis, kind of those joint aches or pains that potentially signal another problem? Or is there gross motor delay? Are they so heavy that, they've had issues with learning to run and jump and be properly coordinated? Is exercise actually a difficult thing for them because of extra weight? Looking for fatty liver by screening with an ALT, looking at fasting lipids, and kind of evaluating sleep and mental health, seeing if there are referrals needed for that. Getting an idea of what their daily routines are currently. Do they play, or how much time do they spend in activity? Is it difficult? Is it something that they enjoy? How much sedentary or screen time do they have? Are they getting adequate sleep? How do they feel about their body image? You know, what is the family all doing the same thing in terms of activity and feeding, or is the kiddo, like, do they have special routines or special foods that they get for some reason? And then taking as much as possible detailed dietary history, what they're eating, how much, how often, where are they eating out, are they having family meals, and why is food being used as a reward, or potential other issues that could contribute to overeating or overfeeding. And then, of course, in our population, food insecurity. How much choice does the family have over what they're eating? Are they going to food shelves? Are they just going for the cheapest thing? What can we potentially do to help there? And, if you come to the end of this evaluation and, the labs are all looking normal, there's the kid is having great activity, they're eating fruits and vegetables, then yeah, maybe I think the health at every size motto is the way to go. Because ultimately we want them not to be experiencing any of the potential health consequences from excess weight. And I think treating the consequences of obesity and the health at every size, they don't necessarily have to be in conflict. This is an example of the health at every size, kind of their pledge, what they say to try to adhere to live at a healthy weight and accept their body size, whatever it may be. And I think the thing to note here is that there's a big focus on intuitive eating. I'll try to feed myself when I'm hungry. I'll be attentive to how foods taste and make me feel, et cetera, et cetera. And, I think what that doesn't address is that often for kids, especially kids who have hit really high BMIs, there are dysregulated signals there. They're always hungry. They never feel full. And so if those signals are not serving them well, what can we do and how can we help them? Because I think for those kids, maybe the health at every size type of idea is not enough, and we could be helpful. Of course, we need to assess, readiness for change. How motivated are families to do something about it, or are they just in a place where you're just giving more information right now? And if they are, motivated to do something and you want to start them on weight management treatment, this is one approach. I think it's called the Barlow approach. And this is from the Pediatric Obesity Algorithm from the Obesity Medicine Association. I think what you want to start with when kids are in that, their body mass index put them into the obesity categories, at least following with them monthly, working on behavior changes, lifestyle changes, and getting them in to see a dietitian so that they can do structured medical nutrition therapy as a first step. Endocrine Society guidelines put these out as the first steps and what to do. So decreasing fast foods, avoiding added table sugar, sugar-sweetened beverages, limiting your non-academic screen time, and then things to do, making sure that you're focusing on family interventions. It's not just one not the kiddo who has a high BMI who gets special treatment or special regulations. The whole family should be in on it. Getting at least 20 minutes a day of moderate to vigorous activity, making sure, they specifically call out to promote self-esteem, to make sure that, kids are not feeling bad about their weight. And then, starting medications if lifestyle changes are unsuccessful, and stopping medications after 12-week trials if they're ineffective. When we're talking about starting some of the medication treatments, often this takes place in a specialized weight clinic. But I think, for our population, for people who are uninsured or underinsured, what can we potentially do in the primary care clinic that I think, you probably could feel comfortable doing, since we do have the support of a dietitian. and some medical knowledge. This is from the Adult Endocrine Society guidelines on obesity medicine treatment, just giving you an idea of, for all of these medications that are approved for adults at least, they're working on specific pathways that either kind of tamp down signals that make you want to eat, or increase satiety signals that say that you're full, you don't need to eat. And you can see some of the more common ones here: phentermine on the left, bupropion, topiramate, and liraglutide. Those are probably medications that you've heard about before. When you're doing an assessment to guide some more advanced therapies, and of note, the Endocrine Society says, medications probably only for kids who are 10 years old or older. Kind of getting more into the specifics of their eating behaviors. Are they hungry all the time? Are they seeking food or sneaking food? Getting an idea of, when does that hunger happen? Is it right after they're eating, they're hungry again? Is it right before? Are they hungry throughout the day? Assessing satiety. Are they eating past the point of fullness? Are they vomiting? So maybe there's just not some signal that says like, hey, you're full, and they need help with that. Or are they having more hedonic eating? Are they eating because they're emotional or coping with negative emotions? Or are they having cravings at a particular time of day or night? Looking at binge eating, whether they have that loss of control or guilt, and what behavioral strategies are being instituted at home. Are they being restricted on food? If they're just eating because they're bored, is the family using distraction, and what kind of response are they getting from the kiddo? And then last but not least, how much are we doing to them? Are they on medications that promote weight gain, especially antipsychotics and the atypical ones in particular? And using this evaluation, you can kind of target some of the medications you can use. So using GLP-1s and phentermine for people who have high hunger. GLP-1s, again, to target satiety, topiramate at times as well. For hedonic eating, using topiramate or naltrexone, targeting that opioid receptor. Lisdexamfetamine is actually approved for binge eating in kids, or in people 18 years and older. Topiramate can be helpful as well. Anecdotally, topiramate is also used for kids who have mood or lability issues or behavioral issues, and then metformin and topiramate actually have evidence to address medication-related weight gain. The ones in bold on the previous page are the ones that are actually approved for pediatrics, and so those are the ones that I'll kind of focus on here. So phentermine is approved 16 plus for treatment of obesity, quote, short term, just because there's not much long-term data. And there are kind of the starting doses on here. Liraglutide is actually a great medication that's approved for kids 12 and older for obesity, titrating up to a max dose that's higher than what it's used for in type 2 diabetes, and has pretty good data for a moderate amount of weight reduction, 5%. That's sustained, I believe, past 6 months. And orlistat is available over the counter as Ally and is approved 12 plus for obesity. It seems like people don't really use this medication just because it has some significant GI side effects, like oily spotting, and sometimes you poop when you fart, so it's not great for teens. And all of these medications are available at a pretty good price from 340B. So are potential options for our patients who are uninsured or underinsured. This is just a note on some of the other medications that are available. I don't want to go into detail on them because it's all off-label treatment use, but know that at least some of them, like metformin and topiramate, they're used quite commonly by the weight specialists. And then when you're starting medications, kind of doing that good follow-up, seeing them monthly, at least for 3 months, monitoring for side effects, and evaluating what is the effect of the BMI. If it's increasing, then the medication's not working, you should discontinue. And if it's not fully effective, you can consider adding another medication. Often a good goal for pediatrics and weight management is stability of the BMI. And just not letting it increase, especially as kids are still growing. And this is always done in conjunction with ongoing lifestyle changes and good interdisciplinary team support. I know I'm hitting end of time, so I don't know, Christina, if we should pause for questions or whether I should keep going.
Thanks, Dr. Ting. I think I can continue recording if you have time to continue and finish it out. The recording will be posted on our website. I just answered a question in the chat about that, along with the slides. So there's a survey in the chat. If you need to leave to get to patients or somewhere else, go ahead and please complete the survey to give us some feedback, and we'll just continue, Dr. Ting, if you have time.
Yeah, absolutely. I think that's fine. So I just wanted to share a couple slides in particular about phentermine. I think people have strong feelings about it. It's been around for so long, and I think a lot of adult weight management doctors will kind of use it cavalierly, but maybe we're more wary in pediatrics. This is a study that was actually published by one of the researchers at the University of Minnesota, showing the effect of phentermine 15 milligrams daily on teenagers who had obesity. And I think the thing to highlight here is it did, in the blue line, you can see produce, more BMI decrease than the standard of care treatment. And the other thing I wanted to point out is that the gray lines here on the slide kind of show individual response to phentermine. So I think here, just because one weight loss medication doesn't work doesn't mean all of them won't work. And, people are going to have different experiences with them. And so I think this is reason to try. Just to show you one example from the Center for Pediatric Obesity Medicine, they had a conference and shared some cases, kind of what weight loss medication can do when used in conjunction with lifestyle change. So this is for a 12-year-old female that Dr. Fox saw, I believe, and had obesity due to strong hunger, family history with limited physical activity, and some binge eating. So you can see in the beginning, she was started on a meal plan and physical therapy, and then started phentermine a couple months later, stayed on the medication, and you can see really made huge decreases in her body mass index, probably along with lifestyle change, but can really produce, I think, an impressive result when, and I think highlights, how impactful these medications can be. I imagine that this patient felt a lot better, was able to move more easily, do all those kinds of things with the assistance of the medication. So I think, this at least impressed me, saying that medications can work. This is a number of the weight management clinics in the Twin Cities. At the U, I think they also have involvement of bariatric surgery. I don't believe any of the other programs have. Alana's program seems quite comprehensive. Hennepin, I know Dr. Luckin and a dietitian work together there. I'm not sure if they also have behavioral health. And then Children's St. Paul doesn't seem to have much of a program, but has something that they do for weight management. I was hoping to talk a little bit about weight management at Kook and kind of figuring out, are we an inclusive environment? Do we have the kind of infrastructure that is supportive for people who are dealing with weight issues? And I think some of these things we have, some of them we don't. I think that's certainly a conversation for the future. I think, what are we currently doing with kids who have overweight and obesity? Are there structured programs or structured, protocols that we could treat or support them with? And what opportunities are there to provide more effective care? I don't know if anybody wants to say anything about those, but there are definitely conversations that we can have in the future as well. And then if anybody has more resources to share, I know I'll be trying to put some of these together in the future to support patients with pediatric weight management. but I just wanted to point out, I got this one from Josie, our dietitian. There are resources that give free fruits and vegetables for families at the White House and the Brian Coyle Center, and you can find the information for that online. I think it happens like twice a month. And some of these other resources can help with, how to talk to patients about weight, for parents about how to talk to their kids about their weight, and some videos actually put out by one of our colleagues in the Division of Pediatrics and Adolescent Health, videos by teens, for teens, for movement and mindfulness. So that's all I had. Thanks so much. Sorry for running late.
Thank you, Dr. Ting. I don't see, we had a question about the copy of the slides be available, so we'll be able to post those on our website along with the recording. And if there are any questions, you can feel free to raise your hand or put them in the chat. All right, I don't see any today. I'm gonna stop the recording.